Everett. I'm the clerkship-level director at the University of Vermont, and I'm also a member of ACE through APCO. And it's my pleasure today to introduce our speaker for our clinical faculty development series 101. And today we have Elizabeth Stuart speaking on thinking like doctors.
All right. Oh, so to do an audition.
Clerkship, clinical reasoning. And Dr. Stuart is currently the director of the core clerkship in pediatrics at the Stanford School of Medicine, and currently the associate residency program director there as well. And for 2 years, she held the position of assistant dean for clerkship education. She's received numerous awards in teaching, including the Golden Apple Award for Excellence in Residency Education from Stanford, and the Henry J. Kaiser Family Foundation Award for Excellence in Clinical Teaching, also from Stanford. And lastly, she received the Franklin G. Ebaugh Jr. Award for advising medical students. And so it's really our honor to have her speak to us today on one of, I think, the most challenging areas of clinical education, which is teaching our students to use clinical reasoning, and how do we assess that. So I'm excited to turn it over to Dr. Stuart.
Okay, I'm gonna try to share the screen. You'd think after nearly 2 years, I'd be really good at it, but I'm still learning to make it work. Okay, so I guess I'm gonna go through kind of the standard slides that come with each of these sessions, just briefly. And these are your CME and disclosure statements. And I think probably people are familiar if you're here with the faculty development series. And so I won't dwell on that. More information. We're right now in January, and a lot coming forward, and then years 2 and 3, I guess. And what I'm going to talk about today is kind of a little bit of a riff on chapter 10 of the ACE guidebook for clerkship directors, focused on clinical reasoning. And Luba and I did this together. Luba is at, I have to say it right, Quinnipiac. I hope I have that right. I'm going to go into a little bit of what's in the chapter, kind of as an overview, but I'm also going to be a little philosophical and hopefully provoke some thinking related to clinical reasoning in medical students. So here are the objectives, sort of simple, thinking about challenges that students face with clinical reasoning during clerkships, and then a little bit on strategies where we can facilitate skill development in diagnostic and management reasoning. These are my qualifications. You heard a little bit already. I have been a core clerkship director in pediatrics since about 2001. I would say it's kind of my main academic role. I'm currently also overseeing the continuity clinic program at Stanford in pediatrics. And for several years, I was director and then assistant dean for clerkship education. And I was editor-in-chief for a while for Aquifer Pediatrics. My sort of other core identity beyond clerkship director, I am an outpatient general pediatrician. And I emphasize that because it definitely creates a filter through which I think about and talk about clinical reasoning. And as you know, all specialties have cultural features, and definitely mine are apparent, I think, as I talk about reasoning. Other kind of elements, I will think of them as disclaimers, but sort of about me. I am very, very interested in the transition to clerkships for medical students and kind of where they stumble. And I think that it's really, there's a significant shift in expected roles and how students learn, whether they're the center of attention anymore. And it's, potentially a little bit stressful. And we ask them to shift from thinking like students to thinking like doctors. And some of them do it very naturally, kind of just by being in the environment, and they are ready. And others need a little bit of support and benefit from deliberate reflection and practice. And the goal of the ACE chapter is really to help clerkship directors and other teachers facilitate that transition. The little picture on the right is from our clerkship orientation slide deck. I believe very strongly that medical students should have truly authentic roles in patient care, and that they are care providers with less experience than other members of the team, and that we can enable them and empower them to take a really meaningful role and add value, not just by sort of being available to patients, but actually by contributing their clinical reasoning and thinking and communication. And so kind of with that in mind, sometimes you'll hear, if you watch inpatient rounds, someone will say, oh, this next patient is being followed by a medical student. And so we're going to need to take some extra time so that we can do a medical student presentation. And I think I would challenge everyone to question that. And if the accepted standard for presenting patients on rounds for a resident is kind of in one way of being, we should be pushing students toward that and not separating them out as needing to do something very different and not practical. So I think that that's, again, not everyone feels strongly about that, but I do, and I want to make you aware of that before we dive in. So kind of here's the plan. I'm going to go through some models and frameworks and terms related to clinical reasoning that may be more or less familiar to everybody. Take a look at the challenges that students face, and then a few strategies for deliberate practice and promoting clerkship-level clinical reasoning. And I probably will not do very much. I'll let you know what's in the chapter on assessment. But as with many things, educational assessment is probably the least studied and worked over part of the literature on clinical reasoning. And so I won't dwell there probably. The chapter starts with a vignette. And so I will start with the same vignette as a way to demonstrate some of the key ideas here. If you imagine in outpatient general pediatrics clinic, a 12-year-old boy, and the student is seeing this patient for knee pain. And students relatively new, maybe to pediatrics for sure, but to clerkships in general. And we'll go in and take a very detailed history, and takes a while with it to be very thorough and make sure that all of the data are gathered. And then after seeing the patient, comes out to present to the community preceptor attending a very detailed history of the present illness, review of systems, full past and family history, and a very careful knee exam, as has been learned in the pre-clerkship curriculum. And as the student is presenting, essentially for many outpatient general pediatrics preceptors, this is what they hear in all of the details that may go on for several minutes. These are the points that come across. And a lot of the rest gets filtered out, and the preceptor, kind of hearing these few things, waits semi-patiently to hear the exam and is really listening to hear, is there any tenderness or swelling over the tibial tuberosity? And on hearing that there is, the physician is mostly done with this patient and has landed on the diagnosis of Osgood-Schlatter, which, if you're not familiar with it, is a very common knee pain apophysitis that happens in this setting, in this age group. And the physician has actually landed on this diagnosis fairly early based on probability. Common things happen commonly. And he hasn't heard anything in the presentation, no flags that require a more careful, slowing down, closer thought. And really, the physician wants to get into the room and get done with this patient and move on because there's a lot going on in clinic. But back in the mind of the student wants to go through his thoughtful differential for joint pain, which, by the way, doesn't include Osgood-Schlatter because that's not something that in the preclinical curriculum the student will have probably heard about. It doesn't represent a critical pathophysiologic principle, so it doesn't get used as an example. And so the differential is broad, but not including the actual diagnosis. And some people would argue this is a great moment to stop and teach about joint pain or extremity pain in kids. But your average community preceptor in pediatrics is probably going to disagree with you, staring down a long schedule for the day, particularly if it's COVID time. And furthermore, the physician is going to sort of say, it's not really a differential diagnosis question, this is just what it is, and might have a lot of difficulty explaining why it is what it is. So there's the opening story. And I will now go through some frameworks and terms that are in the chapter and that, again, may be more or less familiar. If we think about this idea of a transition in thinking, I think things are shifting in medical schools, but we still traditionally teach students to gather information and then think about it. And so we teach them in pre-clerkship how to take a generic history, how to do a comprehensive exam on all of the body systems, formulate a broad differential, and come up with an assessment and plan. And if you think about the RHYME framework, which is widely used and probably familiar, it's often presented as developmental stages, so that first you learn how to gather and report data and then learn how to interpret it. But if you look at how physicians think, it's not gather and then think about it. It's really think about what you're going to gather it, and then think about it again. And so the history and exam are hypothesis driven by an initial differential based on very limited information. And when you get to an actual differential that needs to be communicated, it's very prioritized and sort of streamlined, as are the assessment and plan. So we are expecting students to move from one way of thinking to another a lot of the time. So diving a little bit deeper into that, physicians hearing chief complaint and the patient demographics very quickly start to have a view of who is this patient. And the view of the patient's key features can be thought of as a problem representation in the clinical reasoning literature. That's the term that's used. And once they have that, their minds begin to get going on a very early differential diagnosis just based on chief complaint and demographics. And they start to activate stored knowledge of illness in the form of illness scripts, sort of like a mental file cabinet with maybe 1 page per illness and the key features of each illness there. And all of this is happening before the patient is even seen. And then once you actually are interacting with the patient, you go through a process where you are gathering detailed history and exam based on what you've already thought about and refining your understanding of the patient and the patient's findings and problems and refining your differential. And that sort of keeps happening in a mental cycle. And eventually, as you're searching for illness scripts, you get to a point where you say, these are the ones that match. These known entities fit with what this patient seems to have. And so you end up with a working diagnosis and then a final diagnosis. And from there, if you're a medical student, you take all of that and present it to your preceptor. So that's kind of frame for thinking about what's happening with clinical reasoning and some of the terms. A lot of the literature on clinical reasoning talks about different systems of reasoning, analytic and non-analytic. And as they sound, analytic reasoning is this sort of deliberate matching of patients' findings to stored knowledge, sorting through your mental file cabinet, and is relatively slow and thoughtful. And the kind of other, on the other end of the spectrum is non-analytic, rapid fire, intuitive reasoning, where it just sort of comes to you quickly based on pattern recognition and experience. This is what's going on. And the truth is that physicians use both of these all the time, back and forth. And a critical part of being effective at clinical reasoning is actually knowing when you need to shift and when one feature doesn't fit the pattern that you think could be explaining the patient's situation. And so you need to slow down and go back through and be deliberate in considering. So fast and slow thinking is the other way that that's framed. And there's a lot of literature on that. So with that kind of background, I want to think for a bit on kind of the challenges that students face as they transition. The reality in clerkships is that most of the teachers that students are working with are primarily clinicians, and it depends on where you are and what setting the students ending up in. But the people who are helping students learn what they need to know and learn how to do what they need to do are primarily seeing patients and bringing students along with them. And as I've sort of alluded to already, the data gathering in the clinical setting tends to be fast and hypothesis-driven, focused, efficient. Clinicians and sort of advanced practitioners have what's called encapsulated knowledge. So we don't easily get back to pathophysiology or the reason why a particular symptom appears in a particular illness. It's all sort of built in and hard to retrieve in a way where we can articulate to a student what we're thinking. There's theoretically more non-analytic rapid fire reasoning, pattern recognition in an experienced clinician than in an early student. But again, it's sort of a back and forth shifting between the two. And what we know from observational studies is that clinicians have difficulty articulating their own thinking. And there's Haber and Lingard have a nice set of papers on trying to look at how clinicians make relevance decisions, how to identify what's pertinent in a patient's history and exam, and trying to see how do students learn that. And what they saw is that clinicians weren't able to tell a student why is something relevant or not. They just knew. So this is how students are learning, is in the context of these kind of realities of the clinical setting. Other parts of this, there's a demand for efficiency. You need to go quickly if you are in a setting that's high acuity or rapid pace, outpatient, for example. Clinicians are using secondhand reasoning. And what I mean by that is that rather than going in and seeing the patient on their own and asking the questions that they want to ask to work through their evolving differential diagnosis or planning, they're relying on a student to be their eyes and ears and bring back the correct information. And so that's a challenge that puts pressure on the student to be able to get the information the clinician wants in the way the clinician wants it. I think it's really important to acknowledge that the different teachers that students work with in different settings all have different expectations about what's appropriate, how deep to go in a differential. Are we going to do this in an academic way that looks at theoretically what's possible? Are we going to be practical and think only about what's likely in this patient? And I think that the moving from setting to setting, from preceptor to preceptor, and having to adapt to the expectations is really a huge challenge for students. And then I just want to kind of make note of the fact that at least in my practice as a clerkship director looking through tons and tons of evaluation data, the most common feedback that students get from residents and faculty is that they should read more about their patients and that they should streamline their presentations in particular, both data gathering and presentations, to focus on the pertinent positives and negatives. And those two pieces of feedback may not always be entirely helpful. So let me go forward. Framed another way, these are some of the tasks, learning tasks for students as they come into clerkships. They need to learn a lot of new things, but they also need to organize their knowledge in a way that is relevant to clinical reasoning, that facilitates retrieval of information in the service of generating a differential or interpreting information to know what to do next. Again, a lot of emphasis on focus and efficiency. Students need to learn how to pay selective attention to key features, and they need to be able to put together a differential that's clinically relevant and prioritized and meaningful to the teams that are relying on them for secondhand reasoning. And then the other thing that I spend a lot of time with my students is the fact that the pre-clerkship years focus a lot, and the literature focuses a lot on diagnostic reasoning and the process of figuring out what's going on with a patient. And then we bring students into the clinical years, and a lot of the patients that they're going to be taking care of come in already diagnosed, depending on the setting. Particularly, I can say for sure, inpatient pediatrics, patients come in because they have something that needs to be managed. And we don't really talk about or deliberately teach about management reasoning very much. And I think it's important to acknowledge that, because sometimes students feel that they are kind of in a new reality with that. Okay. Signs of struggle. There are many, but these are some that you will see in students who are needing additional help mastering the clerkship level tasks. When the data that's coming in is unfiltered, disorganized, incomplete, or when you're looking at a differential diagnosis that applies to the problem, but not to the individual patient. So this is the theoretical textbook differential, but it doesn't fit at all with the patient's findings. Frozen differential is one where a patient is admitted, and on day one, there's one differential, and the new information comes in from the lab or from a study and very clearly knocks out almost everything on the differential except one thing, but the student will continue to present that same initial differential. And then everyone's familiar with zebras and getting really caught up in things that are very much not likely. So these are things you'll see in students who aren't quite transitioning easily.
For tomorrow, all the kiddos are flying in, right?
So the photo here, or the little image, I'll just point out for a second, is one that I use with my students a lot. And again, I'm really interested in management reasoning, and a lot of times the students are thinking about efficient pre-rounding and data gathering. And so what I tell them is planning ahead and having a framework for data gathering is important to not end up with unfiltered and non-essential data. If I go into Costco or Target, but especially Costco, without a shopping list, I will go in and come back with a lot of things I really don't need, and I will have forgotten some of the things I really do need. And so having a framework for what information is going to be important to gather is helpful to students, but not always intuitive, kind of how to plan. So I just add that in there. So now kind of some of the strategies that can be helpful to think about to promote clinical reasoning. Very broadly, I think that providing some of the frameworks that we've looked at so far, sharing terms, illness scripts, problem representation, can be really helpful. And I think acknowledging for students these transition issues, that the thinking was a little bit different pre-clerkship than it will be in clerkship, or the thinking might have been different in internal medicine than it is in pediatrics. I often have students coming from other clerkships where certain things were emphasized, and we just do things differently in pediatrics. And being able to recognize those differences and normalize that, at least with my students, has been incredibly helpful, just to be very deliberate about that. Other things in terms of facilitating useful knowledge organization acquisition, teaching at the clerkship level really is best when it's grounded in cases and in clinical findings rather than kind of the theoretical. Linking to physiology, pathophysiology is sort of a way to meet students where they are. They are kind of front-minded about mechanisms of disease, mechanisms of treatment in a way that we're not. But if we can link to the basics, it makes it easier to acquire and organize knowledge. It's important, particularly for diagnostic reasoning, to emphasize comparing and contrasting findings of different illnesses kind of in real time. And so rather than teaching about one thing at a time, teaching about all the things that are related, and I'll give some examples there. So this little diagram is actually stolen from a colleague at Aquifer, but this is bilirubin metabolism, and the asterisks are places where things can go wrong, which will result in different causes of hyperbilirubinemia in a newborn, for example. And you can kind of help students organize a differential based on pathophysiology, again, tapping into what they're familiar with and thinking about as we move forward. I don't know if horizontal reading is really the right term, but rather than having a student who admits a patient with, say, Henoch-Schönlein purpura, you could say, read about your patient. And they might go home and say, I'm going to read all about Henoch-Schönlein purpura in UpToDate, and I'm going to know everything about it. But what you can really do to help facilitate diagnostic reasoning in particular is say, go home and read about purpura. And compare and contrast different causes as you're learning about your patient's illness. And that, again, theoretically helps store information in a way that as soon as you try to retrieve a little bit of information on HSP, your kind of file for ITP and leukemia comes out so that as you're with a patient, you're thinking about all of them easily. So that's just advice about reading. And then just a few little exercises. If you think about musicians, they don't practice an entire piece of music over and over again, all the way through from front to end. But they break it down and do one measure at a time. And there are little things that you can do in the clinical reasoning process that break down the process and give some practice. So I'll go through a few of these just for fun. They are easy to do in short amounts of time. And the highlighter exercise takes advantage of a progress note that somebody's already written. For example, a student picking up a new patient on the ward and needs to get ready to present. And with a coach in particular, it's very helpful to have them go through and put a highlighter to terms or features that they think are particularly relevant to whatever the goal is. So if the goal is to make a diagnosis, then you're looking for findings that will drive you in one direction or another in the differential. And so here's just an example with somebody that we're thinking could possibly have strep throat, but we need to rule out other things. And what this can do is if a student highlights everything, then you know that they need to work a little bit more on understanding the idea of key findings and unique findings for different items on the differential. And again, it's a way to just kind of draw things out. The other one that's sort of related is a little bit of a game where you can sort of say, here's this finding and here's what I think it means. And I need to persuade a doctor who doesn't know me that this is what I have. And so this one is on headache, and you think you have a brain tumor and need a head CT. This kind of was a real thing when I did have strep throat in the middle of flu season and felt like I needed to be very convincing, and thought, well, what am I going to tell this doctor first and second and third? How will I prioritize the presentation of the data to make my case? And what you can do with this in a classroom setting is you can actually give different groups of students an assignment to try to persuade the listener that it's one thing or another. And this, again, facilitates the compare and contrast, but also demonstrates sort of how a presentation can be structured to convey a message. This is just, again, sort of a deliberate exercise to help students shift away from an academic differential to a practical one. And I think that this is particularly relevant in pediatrics, where we tend to be exceedingly practical, and the top three on the differential are the things that happen really commonly. And then we sort of go down to other things that we'd like to make sure students are aware of, but really don't get emphasized in the everyday clinical care. So having a student go back and forth deliberately with these can be helpful to get them used to the idea of streamlining and communicating in a practical clinical way. And then this, it's kind of looks at management reasoning just as a preview, and the sort of taking the traditional SOAP presentation and flipping it so that it's assessment first. And the student is asked to give their assessment and a plan upfront, and then go in and present the data that support that and repeat the assessment and plan. And so the purpose here is, there are a few things. One is that it allows the person listening to match the data that are presented with the assessment and check whether the data makes sense, or is the student kind of connecting things appropriately. And the other thing is, on a practical level, if you're sitting in clinic and a student walks you through something that sounds completely like, say, Osgood Schlatter, and you're sure that that's what the assessment is going to be, and then they arrive at the assessment and say, I think this could be leukemia. Suddenly you have to realize, okay, let me go back and figure out, where did the student go and how did they get to that point? And I think having the assessment in first can have you be primed to listen and then give feedback on the presentation of pertinent data and emphasis. The other thing, again, going back to the idea of authentic roles, at least where I am, if I'm working with residents in clinic, or I don't work in the hospital anymore, as in this case, but in general, we tend to have higher level trainees do this anyway. They come out of a room and they say, I got a 2-year-old with an ear infection. And then they give you all the rest of the information. And I think that we should learn to try that with students, encourage that, tolerate it, if you will, because really that's what we're doing. And the ultimate goal is to take care of patients. And so I will throw that out. A little bit on management reasoning, as I mentioned, doesn't get a lot of emphasis in the literature. One framework for thinking of this to help students identify what's relevant is to get them to be deliberate about identifying a patient's problems and then articulating what are the goals for each of those problems. And based on that, if what we need to do is determine whether a patient is has improving oxygenation, if the goal is for oxygenation to improve, well, what are the details in the patient's chart, on the patient's exam, talking with the parent, the nurse? What are the details that you're going to have to know whether we are making progress toward the goals? And so this is sort of another way of looking at that, starting with problems, going to goals, and then going to details. And students will often say, well, it would help me a lot if before I have to present on rounds, my residents would go through a presentation with me and let me practice. And the reality is residents don't have time in the morning to do that. But what they really can do is go through a student's identification of problems and goals and say, yes, you've got that right. Or if the student can say, I think these are the goals and I think I need these details, the resident can verify that. So it's just sort of a quick way to get the support that they need. But again, these are sort of sources of understanding problems and goals. And this, I think, is particularly helpful if you've got a more advanced student who's quite comfortable, but is taking care of a patient with a diagnosis or a problem that's complicated and needs to be broken down. Students find it helpful to have a frame. Okay, so in the clinical setting, there are a lot of ways to dive in and take advantage to moments during, before, during, and after a clinical encounter. And I will kind of briefly mention those here, and the chapter goes into it a little bit more. Again, back to the beginning, we were looking at the fact that the doctor's thinking starts before the patient is ever seen, and the students should also. And preceptor can intervene before a student goes in a room and say, okay, this is what we know. This is a 12-year-old with knee pain. What are you thinking? What data do you need to gather based on that thinking? What are you going to do? And then the student can go in, and if you have the time as a preceptor, you can be in the room with the student and you can observe the questions they ask, how they approach everything, and then debrief later. Why did you ask that question? How did it help you? Did it get you closer to refining your differential, and so forth? And then there are a number of models that are probably familiar for teaching and promoting reasoning in the context of presentations of patients after a student has come out of a room. One of the things that's very helpful if you are observing a student in the room is to just do verbatim recording. Try to write down each question that the student asks so that you can go back to it and provide very concrete, direct feedback and coaching. As I mentioned, there are tools for assessing clinical reasoning, but there are not sort of 100% validated perfect tools. These are some of the examples. And again, I'm going to let you look at the chapter if you've got access to it, hopefully, for some of the ways to assess diagnostic reasoning. So again, I'm going to wrap up here, and then I think we have time for questions. Pushing students to think like doctors, there are a number of things that we can do. And the huge one is just to acknowledge the transition and the features of the transition. Let students talk about what they're experiencing, what's difficult, where the expectations are mismatched between different preceptors, different clerkships. We've looked at a few frameworks and strategies for guided, deliberate practice. And again, really thinking of students as junior providers who fully can participate and don't need a special carved out way of presenting or doing things. They just need support to be able to contribute in the way that everybody else is contributing. And then for those of you who are involved in pre-clerkship education, I will kind of put in a plug for building the practical view of things in very early and kind of, I guess, softening the transition that happens from pre-clerkship to clerkship and having it not be a different way of thinking, but really the same in greater depth. And so that is what I have for you. Again, ending a little bit early with time to talk, I guess.
Questions? If you have a question, you can type it in the chat. Tracy, I see your hand up. Go ahead and unmute yourself and fire away.
Awesome. Thank you so much for this presentation. It was very, very practical and high yield. I had a question. to you about the University of Miami Miller School of Medicine published a couple years ago how they shortened the preclinical years from 21 to 14 months, and then to start integrating basic science during the actual clerkships. I was wondering, has there been any more research showing if this helps with the clinical reasoning and medical students, just to get the basic, patient info for the 14 weeks phase 1, and then jump right into clinical rotations with the adjoining preclinical curriculum integrated?
I don't know about the research, but I bet that somebody else probably is more familiar. Intuitively, I have to say that completely works for me. It just makes sense. Like, what are we going to be doing? What do I need to be able to do? Okay, now I'm going to learn how to do it. Just makes sense. So, does anyone else familiar?
I'm not familiar, but I can say that I agree with you. But of course, I'm like you, a clinician, and I feel like we need to be shortening the foundation years and lengthening the clinical years. And I'm not 100% convinced that everything I learned in basic science is necessary for me to be a doctor. And so, they've talked about changing it from medical knowledge to knowledge for practice. And I think that if we looked at it in that way, that it would be very possible to reduce and shorten some of the basic science, and then allow for this sort of transition period of growth to apply and really sort of start to think like a doctor before we even do any assessment of students, and then move the assessment piece to the later half of the third year and fourth year. I feel it feels disingenuous to me to have a student, be in foundations on Friday, and then on Monday enter into the clerkship, and in 5 weeks or 6 weeks, I'm going to determine an honor student who's had, little to no clinical exposure, and that just feels disingenuous to me. So that would be my opinion, certainly not based on any research, if you will, unencumbered by data.
Right. Well, and I will throw out also that some make the argument that the basic science is actually really, really, really critical, and we should not cut that out. And I would say that's fine. But if we can put a clinical thing to it and clinical thinking in front of it, then you would just grab that basic science in a way that you're going to use it. And I think that I just feel a little bit like basic science is wasted on the preclinical students. Like, I want it back. I want to sit down and go through it. And it would be much more meaningful to me now, having gone through what I've gone through. So, but again, just opinions. There was a question on the reverse presentation, I think, up there, if I'm reading it right, and how's that going? And I honestly would just say that it is, I push it in my students, and it just makes it easier for me to figure out what they're thinking and whether they're way off or whether they're tracking. I think that actually our inpatient teams have started with their progress notes. The assessment is now in Epic, programmed to be first. And part of that is, again, what are you really looking for? The people taking care of the patients want to know what was the team thinking. So there's that piece of it. But I think that for me, it makes sense as a clinician. It makes my job easier. And I think it pushes students to have to think about how they're going to justify what they've just said. Let's see, I'm not great at chat scanning, so I'm going through watching. Yes, role modeling. He's modeling in clinic at the beginning of the rotations. It's tricky because if we're not aware of what we're doing, it's hard to say, I'm doing this, watch me do it, and have it be meaningful. But if you're mindful about it, and if you're aware of this kind of shift in thinking that needs to happen, and if you in particular can assess kind of where a student is in that transition, then I do think that you can think out loud and show students, I'm about to go in and see a patient, and here's what I'm already thinking. Because I'm already thinking this, I'm going to make sure I get these pieces of information, and then you can kind of go through it that way. So I do think that there's a lot of opportunity and benefit to being deliberate about role modeling.
VJ has his hand up, so go ahead and ask your question.
Yeah, thank you, Elizabeth. I have a question and a comment. I'm struggling. I mean, I've been teaching bedside for the last 20 years. How much structure I should put in clinical reasoning, or I should teach more uncertainty and ambiguity related to the patient at bedside? Because as you bring more structure, I think you lose the real learning of uncertainty and ambiguity. And I feel that we have gone more and more away from bedside, has created more problem for clinical reasoning. I think when a role model and a physician were teaching at bedside, it was not that much problem. Maybe we never thought of it as a problem and we were under training 25 years ago. But I wanted to hear from two of you, Luba and you, that how have you balanced to teach between making more scripted, more structure, more standardized versus teach them more uncertainty, more ambiguity?
So I think my thinking just, I love the question because I don't think I think about it that much, but a lot of the kind of structure here, let me provide a frame for you, let me provide coaching, let me provide a broken down, is when you've got students who need the help, if that makes sense, and they're having trouble filtering, and you're seeing that they are kind of stuck back in a non-practical way of thinking. I think that's when it becomes most helpful to have the structure. And then when you're really in the bedside setting and dealing with somebody who's able to kind of be flexible in thinking, then I think is when you want to emphasize the ambiguity and the uncertainty and catch it and point it out and put it into the frame of, this little piece of information is driving me in this direction now, and that's unexpected. This little piece doesn't fit at all. The textbook would tell me this, and this kid isn't reading the textbook. So now I have to do this. And I think that, I don't think that they're exclusive, but I think that the value in the framing and the deliberateness is when you feel like students are needing help with the transition, if that makes sense. Luba, do you have a reaction to that?
I would just add that I think that's also critically important for the transition from year 3-4 to residency. And I think, Vijay, I love your question because on a day one intern often feels that they need to not have that, that uncertainty and the ambiguity. So I think giving them the structure to bring that uncertainty with them to day one is really, really important, and to model it in all the ways that Elizabeth just stated.
Thank you.
Mike Dell has pointed out something that I think is also important in this idea of the transition, and the idea that preclinically there's sort of a mystery to be solved, and let's think of all the possible solutions. And then what we're looking for clinically is, please just tell me what you think is going on, and that may be jarring for students. And I do think, again, it's important to point that out to people, but yes, I mean, what we're looking for is kind of like a newspaper article. Here's the headline, put it up there, get the point across. And what a lot of students that I run into, you get the sense that their presentation is a source of anxiety and it's a performance. Like, here's my time to prove that I know what I'm doing, that I know the information, that I know my patient, that I can do a good job. But ultimately, the way I see it is the student is the liaison between the patient and the physician team that's taking care of the patient. And the presentation is a tool for advocacy. It's a tool to say, this is my patient. I know my patient better than anybody else. I know what they're worried about, and I need to broadcast that as clearly and cogently and efficiently as possible to this team of people who can help me take care of the patient. And so one of the things that I do when a student seems to feel a little bit of performance anxiety is to really try to emphasize the presentation as a tool for helping the patient, not for helping you, not for showing off. Let it go. What do you think is going to get your message across in the very best way? And it might be a reverse presentation, and it might be something completely different, but do it in the way that you think is going to get the message across. And again, we'll get students then who get written feedback that say, this student should really follow the SOAP framework in all presentations. And, I sort of acknowledge that for you. You're going to run into people who want you to do it a certain way, but you're still the person taking care of the patient. Do it the best way.
I can't find a way to raise my hand on the screen other than to wave my hand, but I'm at the Medical College of Georgia, and we have gone over to the shortened preclinical curriculum. It's a new case for the students every week from week 1. They do have lectures on the basic sciences during that week. And those students have just come to their clerkship now after their first year and a half, and we'll see how that works. The one thing I can say is that most of the small groups, I think, are being done not by clinicians, which I think it's hard to get clinicians to do that, but I think it would be better if they were clinical. But and the physical diagnosis has been related to that, is with clinicians. It's been related to that problem each week as well. So some of our students, actually only a small number, will actually get their MD after 3 years and go directly into a primary care residency. But the vast majority are going to have another year.
You have lots of kudos, Elizabeth, in the chat. So to also take time to read those, always good, especially during COVID, to hear kudos. Any other questions from the group? If not, Elizabeth, I might ask you to maybe just use the last 5 minutes to talk a little bit about assessment. Or maybe give an example of what you're using at Stanford in terms of trying to assess clinical reasoning. I think in the past, assessment's really been focused on the medical knowledge piece. And now we're seeing that so much of being a doctor is, not assessed, like leadership and advocacy and, those types of things. And so would love to hear an example of sort of how you're using this.
So again, I have to say I'm totally a cheater on this. And Luba, if you want to dive into it, that was Luba's part of the chapter, and it was a long time ago. So I'm not going to totally put the demand on her, but I am a horrible lumper rather than a splitter. And so I'll put out a little opinion for you and then see what Luba might add. This is terrible. It violates all rules of assessment, but the concept of entrustment to me is a fantastic concept in the sense of ultimately, what are we trying to do? We're trying to train doctors that we trust to do what they need to do. And honestly, the breaking down of entrustability into how many times can I watch you do something and feel confident is really just not my jam. But the intuitive feeling of, aha, I am listening to you and I'm getting the information I need and we can take care of this patient together. And you've asked me questions that are showing me where you're uncertain and why you got thrown off by a particular finding. And it screwed up your differential, but you're aware of it and you're going back. All of those things make me say, I can trust you to reflect, think critically. And so a lot of our assessment is just completely workplace observation of faculty and residents and kind of where are you on the RHYME framework. But it is not very broken down, deliberate. So I don't have a lot to offer there. But Luba, do you have anything?
I think we're still, as a profession, this is kind of our learning edge. I think the reality for clerkships is that this is usually a part of your global clinical evaluation. All of that being said, I'm not sure that many people are actually assessing this. And so I think thinking about how one might do that deliberately and even giving people the opportunity to do that. I think Elizabeth described a bunch of methods that you could use in the care and feeding and education of clerkship students that actually gives them the opportunity to demonstrate this. And I think often they're not given that opportunity. So I think that's where I am. And I'm a huge fan of workplace-based assessment and chart-stimulated recall. Actually going through a note with a student in a structured way and interrogating their clinical reasoning is another good way to be deliberate about this assessment.
Thank you. I guess I would just counter. I totally agree. I fall into the same camp and I really love workplace-based assessments and really interested in competency-based education and EPAs. And I do think sort of a holistic portfolio review is hopefully where we're headed in all of this. What's concerning to me is that assessment, if we're saying assessment is like at the fringe of where we are, yet 90% of schools are using a tiered assessment or an honors assessment, and that is driving residency interviews. That's concerning to me, I guess. So just a food for thought.
It's messy.
It's messy for sure. We're really struggling with COVID. We went past fail, and now do you go back when the system is flawed? And certainly, as we're hearing, one of the most important things, clinical reasoning, we don't have agreement on how to teach it, how to know if students have it, how to know if they're ready for a particular residency program. So it's a little stressful. All right, looks like people are signing off. Everyone's got to go back to their clinic and telemed visits and things like that. So thank you for joining us, and please join us again in February for another great hour. And we'll see y'all then. Thank you, Dr. Stuart.
Thank you.
Thank you.